for this great initiative to work together under the umbrella of the APEC Educational Committee. Allow me first, as usual, to welcome our guests. And first of all, Professor Sheldon Best, our main speaker today. And I'm sure we will learn a lot from him. This is a very nice article, actually, because the topic is very hot topic. It's one of the most debated in dentistry and in endodontics in particular. I want also to welcome Dr. Ahmed Abdullah, our appraiser today, and hope also we will, under the supervision of our great friend Talal Al-Nahlawi, we will learn a lot also. I can see our president, Dr. Mehmed Kayahan. Hopefully he will join us later on. And I think we are all waiting to start this journal club, which I do believe that it's gonna be of great benefit for all those who are attending us today. Thank you again, Dr. Mohammed, for your great efforts for the APEC Educational Committee and for Tehran University and for the results we are gaining. We are proud that we are the only international educational committee that has journal clubs and international journal club where all our colleagues from around the globe can join us and they can directly make their questions to the main author. And I would like to thank you, Dr. Mohammed, for this initiative, really. Thank you very much. And we are ready to, the stage is open for you and for your guests now.
Thank you very much, Professor Ibrahim. Before I ask Dr. Sheldon Best to start and speak for us, I'm going to welcome all of you again. I can see a lot of popular names and popular faces with us, and I'm going to ask everybody to turn on the videos, then it gives us a very good atmosphere and also for our appraiser. Welcome to all of you. Welcome our colleagues from around the world. I can see Professor Al-Hawaizi from Iraq, from Endodontic Association, Iraqi Endodontic Association. Oh, I can see Chopra as well. Hello, how are you? Viresh, how are you? Great. Yeah. Okay, that's fine. I can see a lot of famous names from around the world to join us. I can see Professor Fazliab, that I know she's ready now to start and asking a lot of questions from Dr. Best. Dr. Best, you are in a very hot chair. Be careful. Be ready for a lot of questions. Okay, Doc. Before I ask you, there is a saying, actually, there's a hadith in our religion that said that man allamani harfan faqad sayyarani abda. And it is very difficult for me to translate it. That means if somebody teach you, you are going to be his servant forever. I can see the name of my professor, Professor Ahmad Qazi Nouri, who actually joined us today. And I remember that when I was a postgraduate student, he was my supervisor in our journal club at that time. So I'm going actually to say hello to him and thanks him for whatever he taught to us. Hello, Professor Sanjay Miglani as well join us from India. So I think we are almost complete and it is exactly 4:30. And as you know, we are planning to be very, very punctual. So Dr. Best, please start.
Hi, assalamu alaikum. Thank you so much. Thank you so much for inviting me to speak with you. It's an honor to meet with colleagues internationally, and it's an absolute honor that you see merit in our research. I would consider this a pro-patient paper. Early in my career, I had a very nice professor tell me that if you treat every patient in your chair as if it was your mother, you will make no mistakes. So obviously, how would I want to treat my mother, or how would I like to be treated myself? I had graduated from the University of Toronto during the Toronto studies. So outcomes were important, documentation. Masa Farzaneh, my Iranian colleague in Toronto, produced a very nice paper. I made it an effort in my career to document every every case. I had observed lesions healing in patients who had failed to show for 1 week recalls. Mostly this was in cases where the patient had full crowns or significant remaining coronal tooth structure. Some of these patients were 6 months or more with calcium hydroxide, and we were seeing lesions heal. So I knew that if we left calcium hydroxide long-term, that it could work. From my perspective, confirmation of healing was very important for a number of reasons. One is from a practical standpoint for the patient value. The patient is being asked to invest a lot of money and time in this enterprise. It would be nice to be able to confidently say, you can proceed to the next level of treatment. The supporting structure is sound. And this is especially important in anatomically sensitive areas where surgical intervention may not be a consideration. In terms of where we live in Canada, I live in a province that is roughly 25% of the landmass of Iran. We have treacherous winter conditions that can make travel very difficult or even dangerous. Many of my patients drive more than 12 hours. We have 3 endodontists for 500,000 people. It would be unreasonable to expect my patients to return for a second visit in the middle of February, for instance, when they're driving 12 hours through treacherous snow conditions. So from a practical standpoint, I didn't have a choice but to have long-term medication. The other consideration is that when I have had a number of cases where the referring dentist has sent patients back to see me with the comments, you did this root canal treatment and it's failing. And I would like to be able to say to the dentist, if you look at the preoperative and postoperative radiographs, you can see that when this patient left my office, this disease process was under control. So the other thing is that when we send our patients back to referring dentists, we have no control over the level of disinfection that they might do. Many dentists are placing posts with no rubber dam, for instance. So I send this patient, we've done this beautiful job of disinfecting. We have no proof of healing if we don't monitor over time. And then the dentist places a post with no rubber dam and the entire system is contaminated. From that perspective, there's a litigation standpoint of who incurs the cost of retreatment, for instance, if the patient comes back with no healing. The other side of this is the personal satisfaction. I mean, we have to see value in whether the treatment that we do works or not. And just being able to watch the healing over time has increased my personal job satisfaction. I had observed that on average, I've been practicing for 32 years. And so on average, I observed that it took about 3 months to see radiographic changes, that convinced me that we were on the path of healing. If you have to medicate long-term, then you must do it in a reasonably safe fashion. So to implement this study, we removed the entire restoration. This was to better able to judge restorability, to remove the disappointment of pre-existing fractures mid-treatment. What I have observed with calcium hydroxide and fractures is that we take patients with severely compromised teeth, which is inherent, of course, in the need for endodontic treatment in posterior teeth. The teeth are severely compromised from a structural standpoint. We place leaky temporary restorations, and we send the patients out to function with remaining tooth walls that are essentially eggshells. It's like cleaning out the basement of your house and then waiting for the roof to leak or collapse. And when the patient returns with a fracture, we scratch our heads and we say, well, it must be the effect of calcium hydroxide on dentin. The saying in English is, you can't see the forest for the trees. I'm fortunate to practice next to my wife, who is an orthodontist, and I had a ready supply of orthodontic bands at my disposal. Cementing a well-fitting stainless steel band, it ensures that no fracture will occur during treatment. In fact, as a courtesy to the dentist after final obturation, I'll place a core in all posterior teeth, and the dentist simply cuts off the band and does his crown prep or her crown prep. And there's no opportunity for reinfection from when the patient leaves my office till the full coronal restoration is placed. Calcium hydroxide was not replenished at any point during this study. And it's likely because I postulate it's possible because we didn't place temporary restorations. We placed permanent restorations. At any rate, I look forward to your discussion and any questions you have. I am thrilled to be here. Thank you.
Thank you very much, Dr. Best, and welcome to Professor Talal Al-Nahlawi, the supervisor of Dr. Ahmed Abdullah. Talal, we mentioned that you are a great professor and teacher, so we are looking for your outcome. And we want actually to judge your teaching skills to see what happened for your postgraduate student today as well. So at the end, we are going to mark your student and your teaching skills as well. So I give you 1 minute to give us an introduction. Please go ahead, Talal.
Okay, thank you very much. Actually, I'm always honored, and I would like to thank you all for always keeping all these activities. All my friends here, Professor Tahoun, Professor Mehmet, Nikofar, all the friends. And actually, it will be a great discussion. Hopefully, Dr. Ahmed will highlight the important issues and will initiate a discussion that will be benefit for all of us. Thank you for the invitation.
Thank you very much, Talal, for your help, for your supervision for Ahmed. And also we have the president of Asian Pacific Endodontic Confederation, Professor Mehmet Bebra Kayahan, my close friend. Bebra, give us 1 minute quick introduction. Please unmute yourself, Bebra.
Is it okay now?
Yes.
Thank you. Please excuse me for being late. Life continues and we are still treating patients. I am very happy to be here, and I'd like to thank you for this really inch perfect organization. And I'd like to thank Professor Sheldon Best for being with us. I'd like to welcome all to our participants. I think this will be a very good scientific day again. Thank you very much.
Thank you very much, Bebra, and thanks for all of you. Thanks, Professor Miglani, Professor Nesrin Taha, and all of you for joining us. Okay, Dr. Ahmed Abdullah, the resident and postgraduate student of Professor Talal Al-Nahlawi from Syria, the stage is yours. You can share your PowerPoint and start your presentation about the very precious article that published by Dr. Sheldon Best. And then please accept my apology if I interrupt you and ask some question in between. And any of the participants, if you have any question, you can raise your hand, obviously electronically, then we can see you and give you the possibility to ask your question from Dr. Best. Thank you very much. Ahmed, go ahead.
Okay, Doctor. Thank you, all of you. It's my honor to be with you today. Today is the third online Endodontic Journal Club. This is Ahmed Abdullah from Syria, Damascus. This is the poster about the topic today we will discuss. The article titled Outcome Assessment of Teeth with Nocratic Bulbs and Apical Periodontitis Treated with Long-Term Calcium Hydroxide by Dr. Sheldon, Christopher, Gillen, Sigurdar, and Peter. I would like to thank Dr. Sheldon for beginning with us today. So thank you, Dr. Sheldon. Calcium hydroxide. This material was introduced to endodontics as a bulk capping agent in 80-20 by Herman. The feature of this material, pH 12.5 and 12.8, and its antibacterial effect anti-inflammatory effect, and osteoinductive properties. The success rate of using calcium hydroxide for teeth diagnosed with pulpal necrosis and apical periodontitis range between 67% and 88%. Studies suggest limiting calcium hydroxide use between 2 to 4 weeks. This is for short period application of calcium hydroxide. Studies with long-term calcium hydroxide use have reported deleterious effect on organic and non-organic components of root dentine structure, like microhardness, elastic modules, and flexure strength. This may cause root fracture. This is for long-term application of calcium hydroxide. For our knowledge, there are no clinical studies demonstrating the association between long-term calcium hydroxide exposure and fractures. The aim of the study, first, to evaluate the outcomes of teeth with necrotic bulbs and apical periodontitis using long-term calcium hydroxide by assessment of healing by the periapical index system. Two, to explore the possible association of fractures due to long-term calcium hydroxide exposure. Material and methods. 242 cases diagnosed with bulbar necrosis and apical periodontitis were treated with long-term calcium hydroxide using a standardized protocol. Inclusion criteria. The age between 18 and 99 of years, good health, all teeth with the radiographic evidence of apical periodontitis and diagnosis of bulb necrosis confirmed by negative response to cold and Alcatrac bulb test were included. Clinical signs of apical periodontitis, such as sinus tract or acute apical abscess, were included. Teeth with sufficient coronal tooth structure for adequate rubber dam isolation were selected. Inclusion criteria: under 18 years of age, medically compromised health status, teeth with a vital bulb status confirmed by diagnostic test, and no evidence of apical periodontitis. Clinical or radiographic evidence of advanced periodontal disease. No radiographic evidence of apical periodontitis. Signs of coronal fractures. Previous endodontic treatment. And no functional or no restorable teeth. Treatment protocol. All patients were treated in a private practice setting by one board-certified endodontist. Remove all of caries and previous restoration were performed under magnification using a dental operating microscope. Canals were instrumented to a minimum size of 30 taper 4. Injectable flowable calcium hydroxide was placed in the canal system. A layer of calcium hydroxide powder was placed over the orifices to serve as a receiver. Anterior cases were restored with composite, and the posterior cases teeth with dental amalgams. All cases were evaluated between 1 and 3 months to assess symptoms and assess clinical signs of apical periodontitis. Outcome measures. The periapical radiographs of all cases included in this study were de-identified and evaluated by 2 blinded, independent, and calibrated examiners. All teeth in question were given a score that corresponded to the periapical index reference radiographs used to assess the periapical healing status. This is the periapical index reference of radiographic healing. 1 and 2 refer to normal periapical structure. 3 and 4 and 5 refer to apical periodontitis. Result: 23 patients were lost to follow-up. 280 patients complete their treatment with follow-up with no sign or symptoms of fractures. The average calcium hydroxide application time was 5.4 months with a range of 1 to 12 months. Most cases demonstrated healing approximately at the 3 months interval. Pre-operative radiographs presented with 216 from 218 teeth with elucence status. At the most recent follow-up visit, 90%, which is 197 patients from 280 patients were classified as healed. 10%, just 10%, which is 22 patients from 290 were classified as non-healed. GABA statistic showed almost perfect agreement for inter-rater and intra-rater reproducibility for both examiners. Discussion?
Sorry, Ahmed, can I interrupt you? Can you please unshare your slides because there are some questions.
Okay.
Thank you. So welcome, Professor Kim. Thank you very much for joining us and all of you again. Dr. Best, I have received a question actually about the way that you select your patient. Because as Ahmed explained, we couldn't see any control or any comparison group in your study. In that terms, if we want actually to say that what is the type of your study, is it a clinical trial or it is just like a cohort or experimental cohort or just comparison pre and post use of calcium hydroxide, something like that? Can you explain a bit more about it? And I understand some of our colleagues also wants to ask the question, Professor Sanjay Miglani as well. So please go ahead, answer this question, and then I ask Sanjay to ask his question, please.
So it's a retrospective cohort case series. However, all patients were treated in the same fashion. So any patient with a periapical lesion was treated with long-term calcium hydroxide. There were no cases treated otherwise. So I don't have a comparison group. Vital cases are done in one visit. Necrotic cases with or without lesions, sometimes without a lesion, I may treat in one visit, but all cases were treated in the same fashion.
So in that case, can we call it as one of the limitation of your study? Because please accept my apology if I ask my question very directly, because the reason is to discuss actually, and I want actually to raise some discussion. The thing is, we always have been told that we need actually to have a control group or a comparison group, because if I ask you, okay, if you don't put anything inside the canal, still it was possible to achieve such an outcome. how you want to show me this was calcium hydroxide that works?
Well, this is what is inherent in a retrospective study. We do not have a randomized double-blinded control. I will throw that out to your students. This is the next stage.
Okay, then. Sanjay, please go ahead.
Yeah, actually, Nikufar, you have already asked my question. My main concern was that there was no control group. And, you know, with today's time, I think when we discuss about a material, we definitely look forward to a control group so that we can know that this was the material, or because of calcium hydroxide, the healing was happening. My another question is, it's a small one. How did you decide on a sample size, and what power do you use? And did you expect any dropouts did you consult a statistician while taking this number, or it was just arbitrary?
This didn't start as a study. This started just as my practice, the way that I run my practice. I was involved with the Royal College of Dentists of Canada as an examiner, and Dr. Tawil, who is the head of the program at UNC, I just presented to him what I was doing in my practice. And at the time, we just went back. I was able to go back and look at whatever size population I wanted. And we just chose between 2004 and 2011, because 2011 was about when we started speaking about this study. In fact, I have data from 2004 to 2021 if I wanted to go and look at it. But it basically, it shows the same results long term. So I probably have a patient pool of several hundred more treated in the same fashion. So the number was chosen arbitrarily.
Professor Nesrin Taha, please go ahead and ask your questions and give us your comment, please. Nesrin, please unmute yourself and ask your question that you already typed.
Yes, good evening. Thank you everyone for being in this challenging presentation. Actually, he already answered one of my questions, which was, is this a routine in his practice to do this type of treatment? And my basic question was, what would be considered a long-term calcium hydroxide dressing? Because the routine is between 1 to 4 weeks, according to study by Orstavik and Jogren, the antibacterial activity would be similar. There was no benefit above 1 week medication. So what was he aiming at when he dressed more than 1 month? And
I was aiming, it was that we were looking at radiographic healing to determine the length of time that calcium hydroxide was placed. It had nothing to do with any particular time other than we would bring the patient back for recall, take a radiograph and confirm healing. That was it.
Okay, yeah. Did you expect a difference if you compared it to a medication for 1 week only?
Well, at 1 week, you can't see healing.
I know, I wouldn't. So you were evaluating after medication, not after obturation. So I meant
no, after medication, yes.
After medication only, yes. Do you have any reference for your technique of placing the calcium hydroxide powder on top of the paste as a reservoir?
No, that was my own thought process. I understood that calcium hydroxide could be washed out of the tooth by previous studies. I know that calcium hydroxide is active in its gel or liquid form. So I just thought, hey, if my restoration leaks, then the calcium hydroxide is activated and serves as a reservoir. It was something I came up with myself. I don't know if it makes any difference.
Mm-hmm. Do you think it will account for the buffering capacity of dentine? You know, because there are studies by Nerwish et al. After medication of calcium hydroxide of 1 week, the pH like inside the dentine, it goes down to around 8, which is almost neutral, 7 to 8. So placing a powder, do you think that it has aided like in maintenance of a high pH inside the canal during this period?
I think so. And I think that's probably why the extended antibacterial effect.
Mm-hmm. Okay. My last questions, like if you want to place a permanent restoration, do you need to wait for complete healing before placing like for a crown?
So all cases that were treated posteriorly, we tried to place a stainless steel band on every tooth, but a permanent restoration material was placed inside the stainless steel band. No temporaries were used at any time. I routinely see patients who have disappeared from the practice. Last week, I saw 2 who had their medication placed 4 to 5 years ago, and they still have the stainless steel band, they still have the tooth, they still have the restoration that I placed. So I think that the thing is that we place temporary restorations which leak. We don't adequately restore the teeth and they fracture. I'm not certain that the calcium hydroxide effect on the structure of dentin plays as large a role in fracture as we think it does. I think it's structurally the teeth are falling apart because they have eggshells to function on.
Yeah, my question was actually like, if you have a tooth with an apical periodontitis, would you be hesitant to do a complete root canal therapy and placement of permanent restoration or a crown immediately? So would you prefer like this long-term calcium hydroxide until you see healing before obturation and final restoration?
I won't treat teeth with lesions in my office in one visit, period.
Yeah,
Just
I know.
Because,
but
so that I'm not sure of the question. What is the question again? Sorry.
Yeah, multiple visits is, I understand it's like when you place 1 to 2 weeks calcium hydroxide, but so you routinely dress up to months until you see evidence of healing before obturation?
The protocol here in this office now is we medicate the tooth, disinfect, place our restoration, and the patient is reappointed at 3 months. I don't see them in between.
Okay.
And at 3 months, I take a radiograph. If we have healing, we proceed to final obturation. If we don't, on occasion, we will wait longer periods of time. And it's not uncommon to wait 6 months with calcium hydroxide.
Dr. Best, do you think, can we recommend to our colleagues to do this type of treatment always? I mean, why
Absolutely.
We cannot fill the root canal in one visit, even when we have apical periodontitis? When we remove the source of the problem, which is the bacteria inside the canal, if we use sodium hypochlorite or other techniques to get rid of the source and the main reason of the apical periodontitis, which is bacteria, then we are able to obturate the canal in one visit. And obviously it is easier for the patient, even in your situation that you said it's very difficult for them to come back. So I think leaving them with long-term calcium hydroxide can make some sort of problem comparing to one visit. So I think Professor Nesrin tried to tell us that, can we use the result of your study and overgeneralize it to our practice and say that, okay, when we have preapical lesion, we have to put calcium hydroxide and we cannot fill the root canal system and obturate it, even if we are able to clean the root canal system properly. So do you want to recommend to us, based on your study, such a thing?
I don't think that disinfection in one visit is predictable. We know that pre-existing canal architecture is the biggest factor in whether we can disinfect or not. And I have no control over that. The system inside the canal is more tortuous and difficult than we think. And by the time a lesion appears, we are dealing with obligate anaerobes and difficult bugs to get rid of. And I would say that it gives me a sense that I have gotten this tooth disinfected. I have not had much success with healing in one visit with these hands.
Okay, Professor Al-Hawaizi, please go ahead, ask your question.
Hello, thank you very much for this meeting.
Thanks for joining.
For this, very nice topic, really. I'm very interested in periapical healing. Many of my cases I post about that. I read that the range of the age of patients is around about 18 to 99 years.
Yes, but from a practical standpoint, we don't see people above age 80, perhaps, you know, and it's uncommon in our jurisdiction to see an 18-year-old or under with a lesion. So yeah, it's just that these patients didn't exist. It wasn't that they were excluded, they just didn't exist.
Yeah, but the problem I think that Professor Al-Hawaizi tried to address to that is when we have a range of the age of 18 to 99, because the healing is a multi-variable situation. So healing is not just based on the removal of the bacteria, it depends on the immune system. And the patients in the age more than 70, they may have some sort of impaired healing system. And then when we put this data together, are we able to go and give a result, such a result that you gave us? Do you think, is it possible to trust to such a result or not when we have a range of 18 to 99? The question is that. I think it's the question of the methodology again.
I think you can trust this information on patients between 18 and 99.
Yes.
That's what I think.
Okay. Thank you. And I think Professor Sanjay Miglani write another question, but that is directly to me, but I want actually to raise that to you as well. It's about the ethical approval. The question is, if we want actually to repeat such a study and say that we are going actually to fill the whole root canal system by calcium hydroxide for a long time, can we get an ethical approval easily to do such a thing? I can say that Sanjay, okay, Sanjay, you go ahead yourself. Sanjay, please unmute yourself. Yes, please.
I have unmuted myself. See, in today's time, if I want to get approval, I need to have a control group and maybe have 2 groups of calcium hydroxide, one for 7 days or a week, and then for a long term. Otherwise, without this, just doing one group for long term, I don't think in our institutional setup, we are going to get ethical clearance. Your inputs.
Yeah, but the only thing, Sanjay, is because this study is a retrospective case series study, that is a bit different, because Dr. Best already did this type of treatment in his practice. So it doesn't need any ethical approval because his methodology is that he chose this methodology. And this is a very good way that we can teach to our students and tell them whatever you are doing in your practice, you need to record that very well, document that very well, then you can publish something. So it's not necessary to get ethical approval.
My idea is there are a lot of postgraduate students here. So in case they want to verify his results, this will be a good randomized clinical trial, having a control group and another group with 7 days and one long-term group. So I think it can come out with a very good result and good study.
Yes, thank you very much. Dr. Best, do you have any comment on ethical approval?
Well, I mean, we do extensive informed consent as a practitioner, and I go through all aspects of risks, benefits, sequelae, et cetera. And I mean, I understand the limitations of this study. I don't have the resources myself to move into, as I say, double-blinded randomized studies. I'd say that this suggests that calcium hydroxide is safe to use long-term. And I would say that this is a platform or a basis for further research.
Okay.
You have to start somewhere.
Dr. Viresh, please, you go ahead.
Yeah, hi, sorry for the background. And if you are hearing some music, I'm really sorry for that. And
that's good. Thank you very much. Where are you?
I have come for a staycation and in a hotel, and the band is going on behind me. So I'm just staying away from it.
Okay, you know that this is a pandemic of COVID-19. Do you know that?
That is why I'm alone with my family.
Good for you.
Okay.
Yeah, thank you.
You go ahead,
Dr.
please.
My question was, what was your protocol for complete calcium hydroxide removal from the root canal before obturation? Number one, that how did you make sure that complete calcium hydroxide has been removed? And second part is that in one of the statements you just said that you can leave calcium hydroxide as long as 6 months also. So coming to think of it, if you are doing a permanent restoration above calcium hydroxide and you are seeing significant healing, do we really need an obturation?
Good question. So my protocol for removing the calcium hydroxide, hypochlorite, EDTA, alcohol, the question of whether we need obturation. I believe there was a study by Clevant and Eggink previously. My suspicion is, and I'm out on a limb for this, but I don't see that obturation adds anything for the patient, honestly. But that's my personal feeling.
Right, and another one I wanted to ask you, how do you means it's might not be related to this study, but if you are leaving calcium hydroxide for 6 months, then what do you think about obturating root canals with bioceramics?
I don't have any experience with it. My understanding was that there was a question of bioceramic expansion and fracture of roots. The other practical problem with bioceramics is hellish to retreat. I don't know much about it.
Yeah, but I think that can be a good topic for discussion. I will go back to this particular one because this calcium silicate based material can release calcium hydroxide, at the same time can seal the canal. So we can discuss later about that. We will go back to that. Viresh, thank you very much for your question.
Sure.
Enjoy.
Thank you.
Please, on behalf of all of us, enjoy. Don't do that alone.
Thank you.
Okay, Fatima, please, you go ahead.
See you. Bye-bye. Thank you.
Dr. Bashtur.
Yes, hello. By the way, I got disconnected.
Oops. Yes, you disconnected again. Please unmute yourself. Yes, go ahead.
Okay, am I? Okay,
yes, we can hear you. Ask your question.
I got disconnected, so I couldn't hear Dr. Viresh's question. I don't want to repeat any question that he asked earlier, but I have two questions actually. One of them is the effect of the weakening of the tooth. If we put calcium hydroxide for a longer period, then it might weaken the tooth, and there's evidence for this. And that might be a question. And also, I have another question regarding the temporary restoration, because we know that long-term temporary restoration might cause leakage. Is that why you added calcium hydroxide powder as a buffer? And also, if so, we know that it will leak eventually. So do you repeat calcium hydroxide dressing before obturating the tooth? Thank you.
I'll go out on a limb. I think that the evidence for weakening of tooth structure by calcium hydroxide as a component of fracture is weak. I don't place temporary restorations. I place the layer of calcium hydroxide, a layer of Cavit, which is a commercial product, and then a more permanent, I use a permanent restoration in a temporary fashion. So either amalgam or composite is placed, not temporaries. And so I've not had to replenish the calcium hydroxide.
Okay, Kavita, please, you go ahead, ask your question, and then we have Professor Fazli. Kavita.
Yes. Good evening, Dr. Shah. My question is on
Kavita, I think your connection is not very good.
Was mentioned around.
I think, Kavita, we cannot hear you very well.
Okay.
But,
okay. Am I audible?
Can you reconnect, please? I can read your question. Kavita asked some question about the dropout was patient, because you mentioned that you lose some of your patients for the follow-up, and it may have some direct effect and sometimes for something like a selection bias on the result. What type of statistical correction have you done for that purpose?
I would say that our loss of patients was in line with other studies. I don't think we lost any. I think actually we had a fairly high rate of return.
Yeah, but usually you need to do a statistical correction that we couldn't find in the results or in the statistical methodology of your study. We tried to find it out. We discussed about that with each other. We couldn't find this correction.
Right. I would have to speak with Tawil. He did the analysis. But
Okay.
I think we were in the 10% range or something for loss.
Yep. Okay, thank you. Professor Fazia, please.
Hi, everyone. Thanks for having me, Dr. Nekufar. Special hello to Professor Sheldon for being with us. As you might know, we have already discussed about this article in our National Journal Committee. And I still have one question. You used long-term calcium hydroxide for two reasons. Actually, the aim of your study was to evaluate the healing after using the long-term calcium hydroxide. And the second aim was to understand the possible association between this long-term usage and incidence of root fractures. Correct me if I'm wrong, but as we all know, the problem of root fracture is the main problem with immature teeth with open apices and thin dentinal walls. The average age of your the study group, I think it started from very early, very young patients to elderly ones. How could you just say that long-term calcium hydroxide can be the reason for tooth fracture even in elderly patients?
I'm sorry, how can I say that fracture?
In case, should any fracture occur, how would you just relate it to calcium hydroxide? Because many of your patients were old enough with thick dentinal walls and you may not expect fracture.
You know, Dr. Best, the thing is, one of the consequences of root canal treatment itself can be the fracture. And if with or without calcium hydroxide, the purpose that Sanjay Miglani, Professor Miglani, and others ask for the control group, I think is that. I mean, for such a study, we need to have a group as a control group without placement of calcium hydroxide and a group with calcium hydroxide, and then compare the percentage and the standard deviation and mean value and whatever statistical analysis that we can do to compare the group with and without calcium hydroxide with each other. Because without control group, if some fracture happens, not because of calcium hydroxide, but because the tooth was carious lesion or some of the cusp or something removed or whatever happened before we do root canal treatment, then the reason of fracture wasn't calcium hydroxide. So methodically, we cannot easily conclude from your study and say that calcium hydroxide can break or calcium hydroxide cannot break a tooth. The question is that, am I right, Mata?
Yes, let me rephrase exactly, Professor Nekufar. I was saying that we think that actually why you didn't choose the clinical trial design with one control group and one, for example, test group. How's your idea about this one?
Okay, so this study was not designed as a study, okay? This is retrospective. We went back to the documentation that I had. This didn't start out as a study. It started out as I treat my patients, you see? So it was only that we
You did have statistical tests, didn't you?
Yes, but what I'm saying is that I didn't start out this looking for control groups or anything. This is how I treat my patients. We just went back to the data that we had collected. In fact, this study did not start out as an analysis for fracture. I started this, as a matter of fact, fracture wasn't even on my radar in 2004. I was looking at healing of lesions long-term. And how could I place calcium hydroxide safely long-term? And it meant placement of stainless steel bands and permanent restorations for my own comfort level. It was after discussing the data with Dr. Tawil, that we decided that we could look at this also from a fracture perspective to say, well, let's look at the teeth that we've treated and how many of them have fractured over time. It wasn't that we had started out to look at fracture.
I think if I help Dr. Best in that situation, I think, Matter, I should say that when we design some clinical trial, we can control other variables very well, obviously. But when we do something in our practice, in our university, in our department, we have huge number of data. And if we have a good documentation, we can publish them as well. So, and in endodontics, one of the problems that we have, we don't have enough evidence. The number of evidence, if we compare the number of evidence that we have in endodontic literature to, for example, periodontics, we can see the number of evidence and the level of evidence that we have is not very high. You know better than me. And if you look at the pyramid of the evidence, the number of clinical trial is very, very low. So the reason is because it's very difficult to get ethical approval, as Professor Miglani mentioned that. Because if you say that I want actually to use calcium hydroxide for a long term, getting an ethical approval is, it's a nightmare. So we need actually to rely in this situation on some data that we have in a very good documented practice like the one that Dr. Best did. So we need actually to say thanks to Dr. Best for this study to give us some idea about how we can use our data in this situation. It is actually my understanding, because I am actually in a situation that I want to make a balance between the question and the answer. So I do agree somehow with you. Yes, as a clinical trial, we need to design something for the future. And the reason that we ask our students to join us in this seminar is because we want actually to give them this idea of methodology. However, to start such a study, we need some sort of retrospective studies like the one that Dr. Best did very well. Okay, thank you, Professor Abu Tahun. You go ahead, and then we go back to Ahmed Abdullah to have the discussion of the study. Please.
Thank you. Just a few words. I think we are being very tough with Dr. Best. Yeah, and I do believe that there is no perfect study on earth. Every study has its limitations. And this is why we conclude always within the limitations of this study. I know all these questions could be ideas for future projects, for future research projects, but the end result is that we have very good follow-up rate, which is almost 90%, which is in these studies is just perfect. We know that this is the main reason why we don't have, as an outcome study, this is a very good outcome study with 90% respondents and with all these results. So I do believe this is a very good study. Beyond any details, I will give my final opinion at the end of this discussion. But till now, the main conclusion is that calcium hydroxide works. It works. Oh, I have many questions to ask Dr. Best, I know. But for example, we know that all calcium hydroxide has a tendency to dissolve over time inside the root canal, especially when we have huge lesions or in hot cases where we have exudate or pus oozing from the canal. I know these are not mentioned, but I think many of these questions were because some of our colleagues, they didn't look up at the article itself, because most of these questions were already answered within the article. I hope we keep this spirit of discussion, but without being tough, because these are legal questions. But I hope.
Brother Abu Tahun, we know you are very kind always. You are very kind always. I can say that in this situation, your wives really enjoy from your company because you are very, very nice always. But and I said wives, you can think that about some sort of polygamy for Professor Abu Tahun. He's very lucky one. Just joking. But definitely I'm not tough with Dr. Best. Dr. Best is brave enough to join us for this discussion. This is the real discussion with the author. And one of the innovative situation that we have in this type of discussion is this, this is this is not a simple webinar. This is a journal club. We discuss a lot and we try to learn from him, and we learn a lot from him. Obviously, we thank him. We appreciate his company and his braveness to be with us. Obviously, this is a classroom. This is a global classroom. This is not a simple webinar. And I told Dr. Best that to accept our apology, to be very straightforward. Thank you very much, Professor Ibrahim. But Dr. Best, I think the question of solving or dissolution of calcium hydroxide from the canal in long term is a big question. I have received a lot of questions about that. When you put calcium hydroxide for 6 months, you should be worried about the solving or dissolution of calcium hydroxide, because these are water soluble and they can be completely gone from the canal after a month or 8 weeks. What do you think about that?
Well, perhaps, let me throw this to you. Perhaps the loss of calcium hydroxide is partially because we use temporary restorations. Maybe it's being lost coronally. As I said, I didn't replenish. I have cases that were 43 months with calcium hydroxide, and we didn't replenish once. Maybe the calcium hydroxide is being lost through the leaking restorations that we place.
Yep. Okay, that's a good point. I think coronal seal is a very important point that you mentioned. Thank you very much. Okay, Ahmed, please go ahead and share the remainder of your PowerPoint. Sorry that we interrupt you for a very long time, but now you see a real discussion. Okay, now we go to the article discussion. Please go ahead, Ahmed.
I have a question.
Yes, please.
Dr. Sheldon, you mentioned in the article.
Ahmed, can you speak a bit louder, please?
Dr. Sheldon, you mentioned in the article you prepare the canal to 30 taper 4. Do you think there is a relationship between the size that you prepare and root canal fracture if we prepare to 6%?
Well, I think it's important to maintain as much tooth structure as we can. So really the size of the preparation is related to pre-existing architecture, but also it's about being able to get your disinfectants to the apex to thoroughly clean. In fact, I did all of this treatment by hand, modified step back. The 30 size is because mostly people are using rotaries. I use rotaries only to spin the calcium hydroxide to the apex. So the 3004 was about the size required to put the calcium hydroxide to position.
Dr. Sheldon, especially in cases with thin root or narrow canal, maybe if we prepare, or in the curved canal, if we prepare to 30 taper 4, there is a relationship.
Yeah. Well, I'm always concerned about fracture of or separation of rotary instruments. My thesis was on separation, so I don't use them. The protocol for size, obviously we should limit tooth structure removal if we can. I hope that answers the question.
Yeah.
Okay, Ahmed, please go ahead, share your PowerPoint, and we are very keen to see the remainder of the PowerPoint, and then we go back to the discussion.
Okay. So let's continue discussion.
Ahmed, we can see your presentation, please.
At baseline, 99 is
okay. Ahmed, we cannot hear you very well. Please again repeat that.
Dr. Nikofar, you
yes,
hear me?
Yes, right now we can hear you, please.
Okay. At baseline, 99 of the teeth were classified as having radiolucence lesion with periapical index system score more than 3, At the last follow-up, 90% had a periapical score of lower than 2, which is classified as a healed or periapical normal structure. To our knowledge, this is the first study to report such a high success rate for teeth diagnosed with bulbar necrosis and apical periodontitis.
Ahmed, can you go back to your previous slide, please? Dr. Sheldon, the last sentence you said that to our best knowledge, this is the first study to report such a high success rate. You compare your study with all other studies that they use calcium hydroxide, or even if they don't use calcium hydroxide, or you just compare them with the one with calcium hydroxide?
This is from Peter Tawil.
Okay. Ahmed, do you know that from the literature? Do you know that from the article? This comparison, is it the comparison to all of success and failure studies, or just to the studies that they use calcium hydroxide? Because this is very important. If we compare that with the whole studies, we need to be very careful again for this type of comparison. Again, Professor Abu Tahan is going actually to criticize me to be a little tough in terms of methodology, but comparison with other studies is very, very tricky. We need to be very careful about this type of comparison. When we want to compare one study to others, definitely these studies should have very, very homogeneous case selection or homogeneous methodology. We cannot compare one study that they use calcium hydroxide with the study that they don't use calcium hydroxide, or with the studies, the range of the patients that they select is different from the range of those. And in terms of PAI score, you select a very good method for scoring the preapical index. But again, if those studies, they don't use this score, it's not possible to compare them with each other. So we this question remains for us to check the article again. Thank you very much. Ahmed, go ahead.
Okay. With regard to fractures, there is currently no available clinical study to validate the relationship between root fractures and long-term exposure of calcium hydroxide. There are speculation that calcium hydroxide exposure alters the mechanical properties of dentin and may predispose the teeth to fracture. The alkaline pH of calcium hydroxide may disrupt the link between hydroxyapatite crystals and the collagen network, which may ultimately increase fracture susceptibility.
Okay, Ahmed, again, stop in this slide. Professor Nasrin Taha has a comment. I think that comment is very important. Professor Nasrin, please go ahead.
Yes, hi again. I just wanted to comment on the issue of high success rate. I believe this success rate is expected because it was performed by in a specialist hand. And if you want to compare, you might compare with literature performed by specialists. We would expect a high success rate above 90%. So like we can't compare, as you said, with the studies performed by undergrads or by multiple operators. So this study had a standard protocol, one operator and a specialist hand. I would expect above 90%. It's the same issue like when we look at outcome of teeth with the retained fractured instrument, like Spilly et al. You find a success rate above 90%, despite presence of fractured instrument because of specialist operator. My second question was for Ahmed, the presenter. Usually in discussion or an introduction by a postgrad, I would like to see some literature in the slides. Like when he talk about available evidence on effect of calcium hydroxide on fracture, it would be nice to add some studies, even if these were experimental studies, just to highlight the differences. And in terms of a clinical study, I only recall the study by Schweck on the fractures, incidence of teeth fractures after trauma, and these were in immature teeth. So as you said, and the author highlight, there is a weak evidence for the role of calcium hydroxide in terms of teeth fracture. Most studies were experimental laboratory studies, and the only clinical study was on traumatized immature teeth, where the root is already weak. And it's not like a standard protocol like in this. So I believe in the effect of positive effect of calcium hydroxide more than its negative effects.
Okay, in that situation, we can say the evidence that Dr. Sheldon Best and his team actually produced for us is one of the very high level evidence that these days we have access to that.
Exactly, despite the study is retrospective in design and is not in the high level of hierarchy, but it provides a very good information that there has been no reports of a fracture in a high number of teeth that has been treated with long-term calcium hydroxide. And when you say 18 years of old, it might be 6, 7, like number 7 or 6, and patient is still young actually, and large intestinal tubules, and over a wide range. I think it's a good thing to have that wide range, because 80, 20, 30, 50 was not difference in terms of fracture occurrence.
Thank you very much, Dr. Besti. I say something very good about you. You actually, honestly, you produce a very important evidence for us, and definitely future studies can use your study to increase the level of evidence. And thank you very much. From Professor Kumars Nazari, we have received a lot of comments. Kumars, can you speak yourself, please? You can unmute yourself and speak up, please. Dr. Kumars. Yes, go ahead.
Hello to everyone. May I ask a question? And thank you, Professor Nekupar, for this webinar. I think we have many limitation from the calcium hydroxide usage inside the canal. As I wrote in the chat part, you can see it's impossible to remove all of the calcium hydroxide residual inside the canal, even using different kinds of the device, such as ultrasonic or endo actuator, Rains endo. Endovac could not remove all of the calcium hydroxide. And in this article, we used very, very resistant to dissolving calcium hydroxide. It means we have many difficulties when we want to obturate inside the canal. As you said, we must remove all of the remnants, all of the bacteria as possible, all of the calcium hydroxide residual. And with respect to tortuous and complicated root canal system that we have, I think it's impossible. And I have one important question. In spite of insertion and consideration from the other my colleagues, I think I can do root canal treatment even with periapical prosthesis in one visit. I have many cases that I get a higher access from the in comparison with 2 visits. And if we want to putting or dressing inside the canal with calcium hydroxide and let him go for about 3 months or 6 months until we see the completed heated, I think it's not logical. It's better to use the comfortable way, an easy way to get higher access. Thank you very much.
Okay, I think, Kumars, we already discussed that part, and I think the only part that I asked Sheldon to answer to that one is about the removal of calcium hydroxide from the canal, because we have received another question from another participant about that as well. Again, the low-level evidence show that it is very difficult. I mean, laboratory evidence show that it's very difficult to remove calcium hydroxide from the canal in the second appointment. What do you think about that, and how do you manage to remove that? I know you already answered this question. Please emphasize on your technique.
Well, I doubt that you can remove it all. I really doubt that. My question would be, why would I have to remove it all? That'd be my question first. Someone commented about the set of zinc oxide eugenol. Honestly, I don't care. It makes no difference to me. And as far as the comment on how one visit works, then show me your paper. Okay, you're entitled to your opinion, but this is what works.
Exactly.
And it works predictably. You're asking your patient in Canada, we're asking our patients to spend $4,000 to do root canal treatment, core, and a crown. It also represents 5 to 6 hours of their lifetimes sitting in a dental chair, time that they will never recover. It's a significant investment, and I want to be able to give them guarantees, period.
Yep. Thank you.
Yeah.
Mahta, please go ahead.
I just want to comment on something. I want to emphasize on something, Professor Sheldon. We are dividing in two parts, actually. Some endodontists believe that calcium hydroxide is the best solution for treatment of teeth with apical periodontitis, and they have many articles with them. One of the greatest ones is you. On the other hand, on the other side of the spectrum are many endodontists that don't believe in multiple treatment sessions. For example, I know that Professor Nekufar is one of those dentists that does not like calcium hydroxide as much as you do. I'm just saying this for my colleagues that this is not a problem. This is a concept. This is a talk of a concept. Many of us have this concept that calcium hydroxide treatment, multiple treatment sessions ensures us that we have done everything possible for the tooth. Some other may bring many evidences that they have done successful treatments with long survival rate with one session treatment. How do you comment about this? Am I right?
Well,
Mahta, let me answer you first, and then Dr. Sheldon. My answer is this is the beauty of science. That is not actually, we are not dogmatic, so we don't say that this is correct, this is wrong. No, no, no. That is the beautiful part of the science. This is not philosophy, because in philosophy, everything is just based on opinion. This is science. Science can be correct or wrong, which is amazing, and I think this is the main thing. So we love this type of discussion because we can learn. Okay, Dr. Best, please.
So all science begins with observation, and I would throw out to your grad students that you can do research whether you're associated with I have no affiliation with any university. You can do research in your own practices. I'll throw that as a plug for research from your grad students. I don't think that belief, as Mata put it, has any weight here. What I believe, what is observed and what is tested is what is important. Whether I believe one visit or 2 visits is better, well, show me the evidence. And I think that this evidence contributes to the body that suggests that 2 visits works.
Okay, thank you. We have 2. Okay, Mahta, you go ahead, and we have 2 more questions. Mahta, you first.
I still believe that this issue, multiple or single treatment session, still remains an issue of dilemma again, and we cannot.
Of course.
Exactly. I'm just saying this for our students. This is a dilemma, and it is still going to remain so.
Thank you, Mahta. Mario from Brazil, you go ahead, and then we have Dr. Velmurugan. Mario, you first, please. Mario, please unmute yourself.
Okay.
Yes.
Thank you. A great honor to participate of this discussion. Congratulations, Dr. Best, for your important study. I include your study in my conference because it adds important information for endodontics in teeth with periapical periodontitis. I think this discussion, especially about single or multiple visits, is very important. I have a question. We have, in our dental school, we use a protocol with 2 sections and calcium hydroxide for 2 weeks. What do you think about this option? I know your option, your protocol is an important option, and we have important data from your study. And we have a great success for this protocol, and we use in teeth with periapical periodontitis.
I think that, you know, disinfection with calcium hydroxide over 1 week or 2 weeks, I'm sure it works. I mean, the evidence suggests this. But what I was looking for was some sort of guarantee of healing. You know, we're like, take the analogy of construction, okay? You're building a house and we're in there and we're making the foundation safe and strong. But unless that foundation is safe and strong, are we going to invest resources in completing the house and putting the new roof on? And so I just wanted to have evidence for the dentist, for the patient, for my own comfort level, that the process was actually showing healing, that the outcomes were good. Because as I say, once the patient leaves my office, I have abdicated responsibility. The dentist is likely going to treat the patient in an asymptomatic, or sorry, it's not going to be disinfected. And so I spent all this time to clean the canal system that is now reinfected. So by taking a preoperative x-ray, so when my patients go back to their dentist, there's a preoperative x-ray, there's a postoperative x-ray showing healing. And mostly now I place my own cores as well. But at least then in future, if the dentist comes back and says, this root canal treatment you did is failing, I can say, well, you know, when the patient left my office, the evidence suggests that this had healed. So something happened in between. It's a comfort level.
Okay, I understood your protocol, but our main challenge here is just to show how important is at least 2 weeks of calcium hydroxide to increase success for teeth with periapical periodontitis. It's our main challenge because great part of dentists, endodontics including, use single session as a protocol for all teeth. So it's very important, your study. Congratulations. I have done, including histological studies in the past, and I saw how important it is for the repair, for the periapical repair. So I think it's very important to continue studying, showing, including this kind of clinical study. Congratulations, thank you very much.
Thank you, Mario, for joining us from Brazil. Velmurugan, please, you go ahead and introduce yourself to us as well.
I'm from India, from Chennai. Hi, everyone.
Thank you very much for joining us. Thank you.
Yeah, privileged to be joining this discussion. Congratulations to APEC Online Club, Dr. Nikofer, and congratulations, Dr. Best, for the excellent discussion. There are 2 points which I just want to bring in for the discussion here. The first one is regarding the fracture. Most of the studies are not indicating the excessive masticatory load on the endodontically treated teeth, which could be an important factor for fracture. So we are not talking about the excessive load. The teeth can be supraerupted, the adjacent teeth is there or not, and these excessive force should be factored in when we are talking about a post-endodontic fracture. So that's one aspect which I just wanted to add on regarding fracture. And regarding the residual calcium hydroxide, why I put the question in the chat box is, it inhibits the closer interface of the sealer with the tubules. And this could be a source. And if you're going to have probably 10% or 20% of calcium hydroxide still remaining inside the root canal, it inhibits the closer adaptation of the sealers. Of course, we are moving away from the ZOE sealers. We are looking at more of your bioceramic sealers or any other sealers. So that's the source of concern. So just wanted the author's opinion regarding his choice for retrieval of calcium hydroxide from inside the root canal.
So Dr. Best, 2 points. One about the occlusion, adjacent tooth, masticatory force, and the effect on fracture. And secondly, about retrieval of calcium hydroxide. Please.
Okay, so in terms of fracture, I agree with this gentleman. I think this is the primary problem we have, is that posterior teeth that require endodontic treatment are hugely compromised in general. And we send our patients out to function on walls of teeth that we know these walls flex incredibly, and we send them out to function as if the tooth is normal, and that's not the case. And as I say, when the patient comes back with a fracture, we say, oh, it must be the calcium hydroxide, and that seems silly to me, when it's more obvious that it's the structural integrity of the tooth. Secondly, as far as it goes, I would put this question about sealers. Do you think they actually seal? So as far as removing the calcium hydroxide because of the effect of delaying the set of zinc oxide eugenol, I don't think they seal at all. I don't think that, what's the medicinal component of gutta perca? There isn't one, right? So a good coronal restoration and serious disinfection beforehand will be more important to you than removal of all of the calcium hydroxide.
Okay, in accordance with your study, Dr. Best, actually ages ago, I did a study on dogs, and I left the canal open and just feel the coronal part, and I showed the preapical healing, very good preapical healing with leaving the root canal completely empty. I do agree with you in that part, but definitely we cannot say that we can leave the canal open for a very long time. Okay, Professor Talal and then Professor Ibrahim. Professor Talal, you go ahead.
Okay, thank you, Professor Nikofar. Thank you, Dr. Best, for this very nice discussion. Actually, I have one comment and maybe 1 or 2 questions, if you allow me. I know
yes,
that we are discussing and the time is running very quickly.
Bring the microphone closer to your mouth, please. Talal,
okay.
Please your microphone closer.
Okay. If you can hear me now, maybe. Okay.
Yes, very well.
Thank you. I mean that I have 1 comment and maybe 1 or 2 questions. The comment that it is very nice article, but if I want to consider the title of the article that you emphasize, Dr. Best, on the long-term application of calcium hydroxide, at the end of reading and discussing this article, I can say, and this is my opinion, that this article will give me no precise idea if there's any correlation between the application of calcium hydroxide and the healing. Maybe because I may change the title, and maybe I will you made non-leaking restoration. I don't know what is the difference now in healing. Maybe the non-leaking restoration, you did it between the visits, maybe the one that help in the healing because you did the disinfection properly at the beginning, and then you
I think Talal is disconnected. Talal, we cannot hear you very well. Professor Tahoun, please, you go ahead, and then we come back to Talal because Talal is disconnected.
Yeah, you stole my ideas. I think you are reading my mind because I wanted to report on your article 2006, but this I will end. What I want to say for all our colleagues, we respect their opinion, who are worried, concerned about leaving some traces of calcium hydroxide. We are leaving 40 to 60% bacteria behind. They are worried about the calcium hydroxide. We always leave bacteria, and we know that. What is the disadvantages of conventional root canal treatment? I think there are very big realizations from this study. I will come to them at the end of this discussion. But what I want to say is that, of course, every study has limitations. But I think let me say my final opinion, my final say at the end of this discussion, please.
Okay. Ahmed, please go ahead and finish your discussion because we just have 10 minutes.
Okay. In contrast of few authors report no association between fracture strength reduction and calcium hydroxide exposure. degrees of fracture strength in a laboratory setting may not correlate well with the clinical outcomes. The influence of any of these property in clinical outcome has not been studied. Conclusion, within the limitation of this study, the use of long-term calcium hydroxide in the treatment of teeth with necrotic bulbs and apical periodontitis resulted in a predictable high incidence of healing. There was no association between long-term calcium hydroxide use and the incidence of fracture during this study. Calcium hydroxide used as a long-term root canal medicament was associated with high rates of resolution of periapical radiolucency. Thank you.
Thank you, Ahmed. Thank you very much indeed. You did a great job. And I can say that, I can say congratulations to Professor Talal by having such brave and very informative students. Can you unshare your presentation, please?
Okay.
What am I going to do? I'm going to ask everybody to turn on their microphone and put their hands together for Ahmed Abdullah first. Thank you very much, Ahmed, for your very great job. And I wish you all of the best for your future. And I'm sure and I trust you become a very good endodontist very soon under the supervision of Professor Talal Al-Nahlawi. Secondly, I want to say thanks again to all of you for joining us. And we had a very great afternoon or very great morning or very great day discussing great issues with each other. What am I going to ask? I'm going to Professor Sanjay Miglani, Professor Kim, Professor Baber Kayahan, Professor Ghazi Nouri to tell us their ideas about today's discussion. And then we go ahead and finish the session by a talk from Professor Baber Kayahan and Professor Ibrahim Tahun. Please make sure that you are going to give us very important topics because we have a lot of students with us. Today we had more than 160 participants and the message, the take-home message from today is very important for us. Professor Sanjay Miglani.
Yeah, thank you, Dr. Nikufar. I just want to tell the postgraduate students that the evidence are not created in one day. They come step by step. So Dr. Best has given us some very concrete evidence. And now it is time to build up on this evidence and go further. So thank you, Dr. Best. I think it is one of the very good studies and has a big number of patients. My appreciation to you and also to the presenter. So it is time now to build up evidence, more evidence on this particular topic. Thank you so much.
Thank you, Sanjay. Thank you very much. Dr. Best, you are the best. Actually, you are the best.
Thank you.
Professor Kim, we need your opinion. Thank you very much for joining us. You are a very important person in the world of endodontics. We always enjoy from your articles, and I know you know a lot about the biomechanics, and fracture is one of your very, I think, interesting topics. Please tell us your idea about this article and today's discussion.
Thank you so much for arranging this good seminar. Yes, Dr. Ibrahim, very nice to see you here. And thank you for the good presentation, Dr. Best. It was very nice to see you this tonight. Yeah, here in Korea is almost midnight, so I'm
oh my God.
But I have to give some comments on this seminar. So during the seminar, I heard that many of you, the participants, are worrying about that when we fail the root canal obturation, when we do the obturation procedure, so with or without the periapical healing. So we are doing the root canal treatment as a root canal treatment. That is not the periapical treatment. So we have to focus inside of the root canal system, the inside, not outside of root. So the periapical region is the kind of consequence or result from the root canal conditions, the microorganism or host defense mechanism, and so on. So we have to focus inside the root canals. So we don't need to worry about the periapical region, the healing itself. So just wait. after filling the root canal. So that is the main rationale, basic principle of root canal treatment. That's what I want to say tonight. Thank you for all.
Thank you very much, Professor Kim. That's a very good point. I think Mahta mentioned that this is still a dilemma. So you emphasize on that, and I am on your side as well. However, Professor Ibrahim and Dr. Best on other side of this spectrum, but that's the beauty of science, as we said. Okay, as I said in the introduction part of my talk, I am very proud to say that I am all servant of my teachers and my professors. Professor Ahmad Ghazi Noori, that you can see him now. I'm going to spotlight his video so you can see him now. Professor Ahmad Ghazi Noori, when I was very young, however, I'm still very young, I was one of his very, very talkative students, and I'm still very talkative. And I remember that sometimes in his class, he said that, Nekufa, shut up. Give the permission to others to speak. So today I did actually all of my talking. Professor Ghazi Noori, I'm all yours, and I ask you to give us your comment, please. Okay, please unmute yourself, Professor. I just ask you to unmute yourself, just still we don't have your work. We cannot hear you very well. Yes, now you can unmute. Yes, please go ahead.
I would like to state my thanks to Dr. Nekufa, and I say that I enjoyed this class and this discussion a lot. It took me about 30 years ago to my young years, and here I would like to translate a poem of a Persian poem. It says that the story of love is always the
Dr.
same.
Ghazi Noori, can you remove the speakers from your video? Because we cannot hear you very well. If you remove the speakers, then we can hear you better.
Yes.
Oh, yeah.
It says that the story of love is the same, but it is different from different languages that you hear, you know. And I remember the time and classes that we were discussing these topics like this, and sometimes very exciting about to prove our ideas that if calcium hydroxide is better of other biomaterial or so on, or the preference is with cleaning and shaping and so on and so on. But anyway, all these discussions are very useful, I think, for education and for science. And one thing that I tell you, and all young people that are present in this class, that science has no end. Science has no end. And it is like a running race that people has a stick in their hand and give them to other people. I don't know the name, professional name of that race, you know, but it is quite like that. We gave the stick to you, and you are going to give to other generation. Thank you very much.
Thank you very much, Professor. Very, very wise, very wise. Thank you very much indeed. Okay, Professor Abu Tahun, you go ahead, and then Barbara, and we end the session by a talk, the last talk, and let's call it last defense from Dr. Best. Abu Tahun, please.
I just want to conclude with a few words. First of all, since the introduction of calcium hydroxide in dentistry by Herman in 1920, it was widely indicated in endo treatment and endodontics especially as a short and long-term intracanal antibacterial dressing material associated with periordicular healing and apical bone healing. This is a fact. So this is a new proof of that. Personally, before the introduction of MTA to dentistry, I have used it in treating of immature teeth with open apices with high rate success. What is the success of root canal treatment? Two main criteria: periapical healing and absence of symptoms. If we achieve them, then we succeeded. This is one. So my opinion is that the conclusion from this study is that the pulp dentium complex has a tremendous healing and repair potential if root canal procedures are accomplished in a fashion that will not impede healing. Because actually we don't place calcium hydroxide in dirty canals. First, we should clean and shape properly the root canals, which means that the primary factor in healing is the disinfection procedure by using the irrigants. This is the main factor for cleaning and shaping, assisted, of course, by the use of non-sitting calcium hydroxide. I remember your study, Dr. Nikofar, 2006, and the fact is that many human and animal studies have shown clearly that root canal disinfection is more important than root canal obturation. And if you achieve a good control of root canal disinfection, and if you can prevent micro leakage, root canal obturation might be not needed. And this is the basis of regeneration and revascularization procedures. So we should be in the right, I'm in the right position to thank Dr. Best because he gave us another proof that it works. Personally, I don't use calcium hydroxide in all cases. In certain cases, yes, retreatment cases, symptomatic teeth, as interim visit for the second visit. I use them and usually I get very good result. This is what I want to say. Thank you, Dr. Best, for your article. I want to thank all my colleagues here who, for their enrichment of our discussion. It was a great session today, Dr. Nikofar. Thank you very much for you, and we are looking forward for the next month. Thank you very much.
Thank you very much, Professor Abu Tahun. Professor Talal, he comes back. Professor Talal, please, you finish your talk. And thank you very much for helping us today, for supervising Ahmed, for the presentation and appraising the article.
Thank you very much. I was continuing, Dr. Best, thank you very much for this article. That the next idea that of my comments, that application of calcium hydroxide for a long term is not a nightmare, as it is sometimes been shown on articles that it will cause a lot of problems. So Dr. Best, he provided us with the clinical evidence for a long time application that it works. But actually I just want maybe a small question for the 7 cases that they were failed and were considered unhealed, and you go for periapical surgery. Did you make any histological examination if there were cysts or were granuloma? And this is another question. What was the irrigation protocol? Did you use sodium hypochlorite as a final rinse after EDTA or not?
Okay. The cases that were surgerized were all biopsied and were all cystic. So it showed that the cases that were non-healing likely had a cystic component. And yes, the final rinse is with sodium hypochlorite.
Okay, thank you very much, Dr. Best. Okay, we have our president, Professor Mehmet Beybarakayahan, in our association, Asian Pacific Endodontic Confederation. We are very proud of this unity that we have between the huge number of countries that we work together like brothers and sisters. We put our hand together and we did a great job. Even in the pandemic situation, we don't stop and we don't feel we should stay at home and frustrated. We work together. And let me say that thanks to Corona, we can now put our hand together better and better and do a better job. Without traveling, we can do this type of scientific gathering. Barbara, thank you very much for your leadership. We are waiting for your talk.
Thank you. The last talk is yours, brother, and I'd like to thank you all for being here. And Dr. Best, what a study is this? It will be one of the cornerstone studies in the world, I think, in endodontics world. And thank you for your informative study, and it will be a valuable brick in the scientific role of endodontics, I am sure. I'd like to thank you all for participating, and I'd like to thank you all, Dr. Nekofar, for the guide of us, and I'd like to thank Professor Tahoun, our president in our education committee, of course, a respected executive board members, Professor Miglani and Henry Kim. I'd like to thank you and for sharing your knowledge. I'd like to thank you all and thank you and have a nice day. And I think next month it will be again a scientific update for our knowledge.
Thank you very much, Barbara. Okay, let me say the last word as well. To be honest with all of you, when I start sending an email to the authors of many articles, many of them reject to be with us in this hot chair. Dr. Best is one of the brave ones who answered to my email just in one day. When I saw his reply, I was surprised because it was just like this. He said yes. And I think when I sent my email in Canada, it was nighttime. And when he wake up, he just answered to my email and say, yes, I will be with you. So Dr. Best, I don't have enough word to say thank you. Honestly, thank you. I don't have enough word. I wish I was there. So I'm going to give you a big hug from APEC, a big hug from all of us. You're amazing. And your smile is full of positive energy. We are going to do root canal treatment in the future with or without calcium hydroxide, but we love you. We love people that they share their knowledge with us without hesitation, without telling us that they know everything. You told us that you know something and you teach us that. Thank you very much indeed. And your name, you deserve your name, your family name. You are the best.
And a big applause to Talal and Ahmed. A big applause to Talal and Ahmed, of course.
Yes, yes, I agree with you. Dr. Sheldon.
Thank you.
I want to thank you so much for finding value in this and for inviting me to speak with your very knowledgeable group. I can tell you that this protocol served very well during the pandemic as we were locked down here in Newfoundland for about 3 months, and I lost no teeth on any patients because they were adequately structurally sound, they were put together properly. This is not meant to be a definitive article on calcium hydroxide. It's meant to add to the body of evidence. The very insightful gentleman talked about the road race. It's called a relay race, and the stick that you pass is called the baton. And I would say that we need to re-examine the role of the endodontist in the treatment of the tooth. We have to look at the patient as a whole. And also, I would say I'm passing the baton to your grad students and saying, now run with this and do some research and let's find a definitive answer. And once again, thank you so much.
Thank you very much. Everybody, please turn on your microphone, turn on your videos, put your hand together for the best authors of our journal club, Dr. Best. Thank you very much indeed.
Thank you very much, Dr. Best.
Thank you.
Okay, goodbye everybody. This is the end of this journal club, and see you all very soon in next month. Thank you and goodbye.
Thank you so much.
Our colleague is going to take some photos, some group photos. So stay with us for the group photos.
Sir, let me come in light first. Let me come in light.
Yes, please go ahead. Whatever you want to say now to Dr. Best, please feel free. The feedback is amazing, Dr. Best. I have received a lot of text about you that you did a great job. Thank you very much all, and goodbye. See you next month.
Take care. Thank you again, Mohammed.